Okay, so now we're going to take a closer look at clinical presentations of spinal cord injuries. If we think about the cervical vertebrae, again, they're the most vulnerable to trauma because they really lack stability. The cervical spine is used for mobility. I'm sure you have remembered your C-spine rules, but I've linked them for you there if you want a little reminder. So this is going to be incredibly important when you're dealing with a patient with cervical pain, that you look carefully and rule out spinal cord injury. Cervical injuries make up about 50% of spinal cord injuries. Primarily, the forces that cause injury are due to flexion or axial loading, a severe force coming from the top of the head down. They could also happen from distraction or extension, rotation, or lateral flexion and shearing. Okay, remember, complete C1, C2 injuries will interrupt, you'll lose function of the diaphragm. Remember C3, 4, and 5 to stay alive. And so these individuals will require nearly immediate resuscitation to survive. When we move on to thoracic injuries, this area, these bones are really made for protection. In addition, we have the ribs that provide additional support to the area. So there's a lot of stability there. So these are going to be very violent injuries, gunshot wounds, car accidents, extreme falls. And most commonly, it'll require a severe flexion force to cause the injury. The other important thing to think about here is that the injuries here, because of the large forces required, are more likely to be complete. And we're thinking about our artery of Adamkiewicz, which has a very large range and even goes as far up as T4. So when you have injuries, you have a severe disruption of the vascular components here. So they're more likely to be complete with a larger area of disruption. And when we're thinking of the thorax, thoracic injuries, T12 to L1, that junction is the most common. And again, as we move to the lumbar area, again, that thoracolumbar junction is going to be the most common injury. It's the weakest link there at the back. Just a reminder that all of those lumbar and sacral cord segments lie between that upper vertebral body of T10 and the level of L1 or L2 when that spinal cord ends. Below L1 or L2, reminder that the cord isn't present in the vertebral foramen anymore. And so we can get a very diverse pattern of neurological damage due to whether or not which nerve roots are impacted. And so these are usually incomplete injuries, which is good news because that gives us the best possibility for recovery. So when we learn how to identify the level of injury, we're going to use something called the Asia Impairment Scale. It's a very complex, it looks like this. And so I'm not going to go into that right now, but you can start to see that when we have a typical injury, we're going to identify the sensory function and the motor function here, and we'll come up, I'll teach you how to come up with a level of injury, but that's for another recording, okay? Right now, I want you to keep that in mind, that we'll get a certain level, and thinking about your tetraplegia versus paraplegia and complete versus incomplete. I'm going to review a little bit about spinal cord segment anatomy because there are some syndromes that come up with very unique presentations, and that's what we're going to cover right now. So it's important that you remember what that spinal cord segment looks like and where our pathways are located, because that's going to be very important. The more that you can remember this, the better you'll be able to figure out on your own some of these other syndromes and what's affected. I've sort of bolded and drawn a line around our major pathways. Okay, the corticospinal tract located here and here, and the spinal thalamic tract primarily here, okay, and then the DCML located here. Remember that the pathways that are in blue are sensory and ascending pathways. Okay, I try to remember that, like the spinothalamic, it goes from the spine up to the thalamus. That helps me differentiate that from the corticospinal tract, which is a descending tract going from the cortical areas down to the spine. Just one way that I try to remember it when I'm trying to distinguish quickly between the tracts. Okay, and the DCML. And it's going to be helpful for you to remember in those what they carry. Okay, so I've bolded the main ones. So the dorsal column, medial lemniscus, conscious proprioception, vibration, and discriminative touch, while the spinothalamic tract carries nociception or pain and temperature and more crude touch. Okay, we still have the spinocerebellar tract for unconscious proprioception. And then over here for the descending pathways, the lateral corticospinal tract, and remember that's our upper motor neuron pathway, enables voluntary movement. Okay, the vestibulospinal tract is still important for posture and balance, but these are the three main ones that will be helpful. Here's just a gentle reminder that there is a somatotopic organization in these areas. So as you look at the corticospinal tract, the head is closest to the center of the spinal cord here, and the legs are further away. Same thing here with the spinothalamic tract. The head is closest to the center. Okay, so that's going to be important in some of our syndromes. Here's another view, just reminding you that sometimes though we label them on one side, we have both of those areas, both of the corticospinal tract on each side, 2 DCMLs, etc. The anterior cord syndrome, and you see here is shaded in this purple color. There was an anterior cord damage, which usually is a result of an infarction of the anterior spinal artery or damage with a very severe hyperflexion injury that compresses that artery or causes a blood clot. Sometimes happens during surgery. And you can see that the anterior 2/3 of that spinal cord segment are damaged. This is going to result in a motor complete. I hope you can see that because both of our corticospinal tracts will be damaged, right? Okay. But we'll also have impaired pain or nociception and temperature, okay, due to the spinothalamic tract being damaged. But the DCML is spared. So we'll still have, in this kind of a syndrome, proprioception and vibration will be intact. Posterior cord syndrome is just the opposite. We're only going to have the posterior 1/3 that's been damaged. We still have that anterior 2/3 that's intact. This is usually caused by some kind of penetrating wound to the back or a severe hyperextension injury that might fracture that vertebral arch. It's a lot more rare. But in this case, proprioception and vibration are lost, but nociception and temperature and motor function are all intact. Okay? And I hope you can see that just by, spending more time studying and remembering where those tracts are located, that it will make it much easier to remember these syndromes rather than trying to memorize them. Now, central cord syndrome is very different. You're going to see damage to the central part of that segment with sparing in the periphery. Okay, this will happen with some severe trauma or a tumor or a syrinx like we talked about in pediatrics, where you get fluid in that portion of the canal that will put pressure from the CSF in that canal. Okay, the trauma that usually occurs is due to, in older individuals, a fall where they sustain a severe hyperextension injury of the neck. You can see that down here. Okay. In this presentation, remembering that somatotopic presentation, the upper extremities are much more affected than the lower extremities. So many times these individuals are able to walk. There's also usually sparing of sensation in the sacral region, and many of these people have sacral motor function. Okay? But they lack the ability to use their upper extremities. So if you think about that, while gait is preserved, the ability to care for yourself and do ADLs is severely disrupted. One of the ways that I remember this is from one of my patients who couldn't really attend to his nose. That was very distressing because he had a hard time breathing because he had some blockages. And so, thinking about the fact that he couldn't clear his own nasal passages and how disrupting and that might be. I hope that helps you to kind of stick that in your brain. So central cord syndrome, they can walk, but they can't really use their hands. Brown-Sequard syndrome is going to be a brain breaker. So we're going to have to think pretty carefully about it. What happens here is that we get a hemisection of the spinal cord that's injured. Okay, usually due to a fraction or dislocation or another penetrating injury, a knife or a gunshot. One side is injured, one side is spared. Okay. So this is when you're going to have to remember the tracts and which ones cross where. Okay, so on this side, the DCML will still remain, on this side will be damaged. So we'll be missing proprioception, vibration, deep touch, discriminative touch, and voluntary motor control because we've lost both the DCML and the spinothalamic tract on that side. Okay. Thinking also that we're going to have hyperreflexia because of the effect of the spinothalamic tract. So we're going to have loss of proprioception, vibration, and deep touch due to the loss of the DCML, and that's going to be ipsilateral to the lesion. We're also going to have loss ipsilateral to the lesion of voluntary motor control and discriminative touch. Those both travel up and cross in the lower medulla. Because of the loss of the corticospinal tract, you're also going to see hyperreflexia ipsilaterally. Now, the spinothalamic tract crosses in the spinal cord, and so contralateral to the lesion, you're going to see a loss of pain, or nociception, and temperature and crude touch, contralateral to the lesion. But pain and temperature and crude touch will remain intact ipsilateral to the lesion. So, it's a brain breaker. You can either remember your neuroanatomy or you can memorize it. But here's a little bit about what it will look like in this individual who has a lesion on this side. He'll lose the DCML and the corticospinal tract on that same side, but contralaterally he'll lose pain, nociception, and temperature.
Or you can think about it from a neuroanatomical perspective. So if you think about the corticospinal tract, it's a descending tract. It's coming down from the cortical area, crossing in the lower medulla, and coming through the tract down. So if we've lost function on the left side of the spinal cord, as in here and here, then the left corticospinal tract will be affected. So you'll lose motor and any hyperreflexia will happen ipsilaterally. Okay. The DCML is an ascending tract. It's coming up through the spinal cord, also crossing in the lower medulla before it goes up to the cortical area. Okay. So you'll also lose proprioception, vibration, deep touch, discriminative touch on the left side ipsilaterally. Okay. Contrary to that, the spinothalamic tract, also an ascending tract, but it differs because it crosses in the spinal cord and then travels up to the cortical area. So, different from the other tracts, the spinothalamic tract will be affected on the right-hand side. So contralaterally, the person will lose function of pain, temperature, crude touch, contralateral to the lesion. Okay, I hope this is helpful.
Okay, so here's a quick review of where the spinal cord ends. Remembering that spinal cord injury is upper motor neuron lesion. Remembering that you have the conus medullaris down there at L1, L2, and below that you have the cauda equina. Okay, and that the cauda equina is a lower motor neuron injury, where the conus medullaris is both upper and lower motor neuron injury. So now, as we look specifically at conus medullaris injuries, again, reminder that you're going to have mixed signs, upper motor neuron and lower motor neuron lesions. Usually at the L1 vertebral level, we're going to see deep aching pain in the low back, numbness in the groin, thigh, leg, or foot bilaterally. We're going to see changes in bowel, bladder, and sexual function. Okay? We're going to talk a little bit more about those changes when we talk about medical complications. In contrast, when we look at cauda equina injuries, those are usually occurring below the L2 vertebral level. You're going to see multiple lumbar and sacral nerve roots damaged, caused by the herniation of a disc. It's a little difficult to clinically differentiate from the conus medullaris injury, and that's where you're going to rely on some of your examination techniques that we learned in the first semester. Some of the symptoms that you're going to see are severe stabbing back pain, more radicular in nature, and along those dermatomal patterns. Okay? Symptoms are typically unilateral, but the pattern might vary depending on the extent of the damage. And again, you're going to see a reflexive bowel and bladder, and we're going to discuss that further. So if we look a little bit more carefully at myelopathy and radiculopathy, a radiculopathy is when that disc protrusion is a little bit more lateral and it puts pressure more on the nerve root itself. And that's when you're going to see lower motor neuron symptoms. That's when you should be using in your examination that triad, the myotome, dermatome reflexes. Okay? And that's going to be unilateral because it's on one lateral side. All right? As opposed to myelopathy, where the disc protrusion is central, impinging the spinal cord, and you're going to see that upper motor neuron symptoms. You're going to see it's most likely going to be bilateral, and you're going to see what's known as a myelopathic gait. I think you can picture the weaknesses that this patient might have in their hips. And so they get to try to do the weight shift. They're going to lurch over that side. You're going to see a bit of Trendelenburg. So it's a lurching and wobbly gait. And in addition, you can think about the impact that it might have on that DCML, where they lack or some of the proprioception is impaired. And so it's a very clumsy lateral wide base of support to help gain some stability type of gait. And so that might be something that you pick up in your examination, because again, remember, these are examples of non-traumatic spinal cord injuries that you're going to use your great clinical examination to help start to tease out and decide if that person needs to be referred out or refer and treat. And I'm going to let you go ahead and stop the video and watch this video, which is a good demonstration of myelopathic gait.